pleasure to welcome you to today's session as part of our GenViR seminar workshop series, where we'll be looking at the policy landscape and the process of bridging the work of NGOs and policy and policymakers. We've got three brilliant speakers today, and those of you who've logged in before to these seminars will be familiar with the format. We've got three speakers. We've got approximately an hour and a half remaining to us. So it'll be divided up into three parts. I'll invite each speaker, because Aditi, one of the speakers, isn't with us yet. We will actually start with Alli, even though on the original agenda she was second. But in theory, at least, we'll have three speakers. So in a moment, I'll invite each speaker to talk for 10 or 15 minutes, perhaps about their work and what they see the issues to be. And then we'll pause and there'll be time for questions and points for discussion. And I'll be chairing, I'll be trying to keep everybody to time. And hopefully at the end, there'll be time for a little general discussion and some final reflections from the speakers. I'd just like to remind everybody that this session is being recorded, so I hope everybody's okay with that. Just bear that in mind if you want to ask a question, to prevent interference and feedback. Unless you're speaking, if you mute your microphone, that would be appreciated, but don't forget to unmute when you want to say something, of course. The recording will be made available on the GenViR website in due course. Okay, I think that's the preliminary remarks over with. First of all, then it's my great pleasure to introduce Alli Bhaskar, who's been working with, and I'm never quite sure how to pronounce this organization because it's originally Italian. It might be CESVI rather, or CESVI. Anyway, Alli was an accountant originally, but has worked for the last 18 years or so for the development sector, primarily with CESVI. And her expertise lies in enhancing the capabilities of NGO staff in various areas, including accounting, finance, statutory compliance, grant management, legal compliance, and the formulation of operational policies. Gosh, it makes me feel tired just to talk about that lot. So I certainly admire your energy, Alli. She's been performing a leadership role in CESVI India, guiding the organisation with strategic vision, fostering proposals infused with a gender and innovation perspective, and providing support to partner organisations during implementation. Okay, so with the introduction done, take it away, Alli.
Thank you for this introduction. Actually, I was, Nadia was aware I was preparing for another topic, which thanks, though I was not presenting that, I've learned a lot because it was bridging the policy of the Indian policy towards gender, and I interacted with some NGOs who are specialized in gender-based. I've learned something, but by the time I could do, I realized somebody's taking care of that part only very late. So, but it was a learning experience for me. I had a good knowledge shared by the other big organizations who are working on gender-based and the policies and all the gaps and all that they were sharing with me. Yeah. So, but now it was said like, what is CESVI and CESVI's role? So I just thought I will just talk about CESVI as what Brown has said. It is pronounced as CESVI only. Yeah. So it is an Italian organization which was established in 1985, and it is working for global solidarity. Next slide. The mission and vision of CESVI is like CESVI operates worldwide to support the most vulnerable population, promoting human rights and for sustainable development. Its vision is also to recognize the human rights which contribute to everybody's well-being and on the planet, and shared home to be safeguarded. CESVI has been working in almost 22 countries and like on rural development. The sectors where we work in these 22 countries are related to rural development. We have inclusive and sustainable growth, protection, health, civil society, and governance. Protection is one of the sector which we are working in India from the beginning, which I will be later discussing the project, international project in India. I would like to share about the core humanitarian standards which SWI is committed to, and as an alliance it has been committed to this core humanitarian standard alliance in 2015. Thereafter, in 2018, SWI is a core humanitarian standard verified organization as such. These are the 9 commitments in the core humanitarian standards, which are appropriativeness and relevance, effectiveness and timeliness, building resilience and do not harm, participation, complaint management, coordination and complementarity, learning and improvement, people management and resource management. In detail, under each of these headings, if anybody who wanted to interested to know on these commitments, maybe I can share it later also. To talk about CESVI. CESVI is alliance, part of an alliance of the European Union organizations. 7 European organizations are part of the alliance 2015, of which acted. We have Iodine Action, CESVI, Concern, Elevitas, People in Need, and Weltanga Welfare. As a network, we are implementing many projects across the world, not directly as CESVI alone, as also an alliance member in every country. Even in India, during emergency, in India there are 3 of the alliance members are working here. We have acted WHH, which is Weltanga and CESVI. All of us together have done some work towards disasters when it happened in Orissa, West Bengal. So as an alliance, we also work together in India and also in other countries. More than 2.3 million are directly reached through 113 emergency or development projects in India. I will like to talk about India in specific. Earlier I was talking about my headquarters and all the work we do around the world. Now specifically to India, CESVI started its work in India from 1999 and 2001. It was only during emergency. From Italy, they come forward, they work here, and then after the relief, they leave India. But from 2002 onwards, we had started having projects in India, long-term projects of 3 to 4 years. And we started having a registered office in India after 2002. So we were working with occasional training and microcredit in Tamil Nadu, where we were working with the women, and across all the activities, gender is one of our cross-cutting, and we emphasis on gender-based violence or violence against women, and though education and children is our priority of the work, keeping children as center, we also work with the family, especially with the women's group. So we started as a occasional training in 2002 to 2005, and a microcredit. Those years, self-welfare group were not that very uh, did not grow that fast as what it is now, but we started working with them. We created women's group and supporting them in microcredits. Then with tsunami, we had our intervention because CESVI is basically works on emergency. So for tsunami, they were here and we were working not only at the time of relief, but even after rehabilitation, we've started working. And along with it, we constructed 3 House of Smiles, we call. These are our flagship programs. House of Smiles is a residential home. We started as a residential, but now all our projects, we call it as House of Smile. But in 2005, we developed 3 House of Smiles where the children who have lost their both the parents were given was the criteria, and we were providing residential care. 2 were boys' homes and 1 were exclusively for girls in the coastal districts of states of Tamil Nadu. We provide shelter care there, and maybe I can talk about this House of Smile in my last slide also. Then we had a project on child labor eradication in Tamil Nadu and Karnataka, again working with the children. And in Tamil Nadu, we work with the bricklin and rice mills, with the women also, and in Karnataka with beedi rolling communities, and also slum communities there. We had micro enterpriseship in Kerala and Tamil Nadu, where we work with the women on vetiver and jute production. From these vetiver, they were able to produce a kind of a perfume oil, which later, and we also supported them in marketing internationally, and now they are sustainable. Similarly, with the jute productions, these are all, we just don't provide them training. During the training, we give them a lot of awareness. We talk about sexual harassment, we talk about gender-based violence, and support, or to which is the main, like they should be sustainable, but apart from that, awareness is being provided. From 2014-18, we did one big European Union project in the 5 backward districts of Karnataka, where all the government schemes could be accessed by those community. This was a big impact in our project, which I will also later talk in detail. And we, as an alliance member, as I said, we responded to the cyclones in Orissa as well as West Bengal. So when I was talking about this community engagement and on this topic, like I'm taking this work we were doing between 2014 to 2018, where we were working on to access the government schemes in the 5 backward districts of North Karnataka. So in this project, we created awareness to the community on to understand, to access their rights, organize and strengthen the groups as such, and link them to the service, and also the governance capacity of the local government system. In this project, we also worked with the local authorities, giving them, that is, enhancing their capacities also. In this project, we created as such like a community CBOs as such in each village where we worked. We worked in 100 villages. So we created a 10 members group. The majority were from women. So we trained these groups So to motivate the other members to access the other community people to access the public schemes. These 100 or 1,000 members in these 100 VRSSG groups were formed by us, trained, and they were the gaps between the community and the government. Later, we created at the Gram Panchayat level and also at Taluk level. And the thing is, like, we registered these groups. At the end of the project, we ensured these groups are registered because they were doing a wonderful job. They were participating in the Gram Panchayat. They were talking to the officials and they were ensuring, like, during what budget the village should get it and what actor they were planning actually with the government authorities, with the local authorities there. A good example of a community engagement activity this is. And to talk about this project again, like there was no monetary incentives given on this project. It's only knowledge which we were providing through awareness and training programs. And these members, we call them BRSSG, like, backward region support scheme support group members. Actually, from the training, they became a TOT people, and then they started motivating the community and facilitating them to access the schemes. And also, as I said, to work with the local authorities to monitor the funds allocated. And also, they were as like a grievance cell between the community members. Various methodologies were followed, as like in all projects. We had some street plays, folk theaters. Then we had some interaction with the PRI members, district authorities. We had mass awareness, mass contact programs through which we were spread this information. And through this capacity building, we did not there was no monetary incentives given, but there was so much of schemes available which has been declared by the central as well as the state government. The impact was 677 million were transferred, or these were the entitlements were received by the 5 backward districts in the 100 villages. These 677 million were the government funds which were already allocated to them, which sometimes go unspent and return back. But this includes building of schools, like even water facilities, connecting water, road, PHCs, so many things. So we have also documented this and by a big documentary film. And also this was evaluated and an audit was done, and this information of 677 million of government resources which have been entitlements received by the community people, the village people were approved and said these are the right figures. That we have been monitoring it from the beginning of the project. So we are working as House of Smile project in Tamil Nadu, which I already said, in Tiruvallur and Kadalur districts. And under the CSR program, we also call it as House of Smile in Mumbai and Pune. This CSR program, I could like to tell, like once the CSR became a mandate, we started, maybe next slide. The House of Smile is a flagship program for CESVI, where we work for women, children, and adolescents in vulnerable situations. As I earlier said, our main initiative is psychosocial care and educational support. And as I earlier said, again, residential care for children. We have girl children at Ekta and boys at Jeevajyoti. Actually, CESVI doesn't directly implement, it works only in partnership. So that it's another way of, as an international organization, we develop the local NGOs and give them all the capacity building, organizational structure. We also structure the organization as such. So from the beginning till now, we don't directly implement any project. We work only in partnership. We identify within a call for proposal on the base of the topics. If we are going to work on child labor or on education or on access to public schemes, we identify the partners, and we also train the partner organization, and also to ensure the partner organization become a bigger organization getting huge funds. We train them on policy development, fundraising, and also proposal writing. So like Ektar and Jiva Jyoti, when we started, they were a very small organization. Now they have n number of projects, and this House of Smile will still continue from 2005 onwards. Ours is a very small project with them now. So the main activities under this, we provide residential care along with nutrition, health care. Counseling is one of our major initiatives, and children participation. We have children library, educational materials, and parents meetings are there, the volunteers visits, exposure visits, and children camps, skill training, which we have open it in and around the community also. We do tailoring and tailoring beautician courses, computer courses, keeping our shelter home as the center and for the local communities there. Our CSR programs, like as I said, when the CSR came into, like, as a policy where every corporate sector has to spend a certain percentage of their money for social activities. CESVI started its collaboration in 2015, and these Italian companies were identified, and they approached us because of our long presence in India, and asked us to do a joint planning for the CSR, for them to implement and to use their money for the CSR activities. So this is how we do it for the, like SWADHAR is one of our partners through this. We do a CSR strategy development and planning. Then we also do a program, CSR program and definition and selection of a local partner for the CSR company. And once the project is designed, the budget is designed, we enter into a MOU between the CSR company and the local partner who we have identified. And after that, we also do the monitoring of the CSR implemented projects. These are the 10 steps, like what we do under CSR strategy and planning, where we identify their programs. Then we give a clarity on the budget and timeline. These are related to the companies as such. Then based on our experience, like we share the sectors based on our experience. We don't take up even if the company tells on climate change and all that, we are expert with education, gender-based violence, women kind of activities, occasional training, psychological support. So these are the sectors where we are globally and in country are experienced. So we could try to work only on these areas of implementation. Then we also develop program strategy and framework for the NGOs. Then we will identify the NGO. We will put a call for proposal and select the NGOs for this. Then we will enter into all the administrative procedures of drawing an MOU and between the CSR, the corporates, CESVI, it is a tripart agreement as such. And after that, we do a regular monitoring of the project on the field, on the program part, as well as on the financial part. We strengthen the NGOs with whom we are working with on all the administrative procedures and policies are in place, and we will also ensure that we give a quality reporting of the activity to the CSR company, and the impact of the project is also being measured through various tools which we have, like the log frame, the M&E tools, monitoring and evaluation tools we maintain. We will also measure the impact of the project, and if there is any corrections, we will also inform the NGOs accordingly. Regarding this CSR program, we have one women empowerment and daycare center in Mumbai, and similarly we were working with, that is with ProAction, a local NGO, and we are working with SWADHAR on focusing, like it's an integrated hub approach for community development, where children education focusing on also women. So this is, so both are called as House of Smile, that is House of Smile Mumbai, and it's House of Smile Pune. Under the House of Smile Pune, which I think so all of you will be aware, again it is children, working with the children on their education. Not only that, we focus on families. For the children, we have activities related to kindergarten, and where the children, before enrolling them into schools between the age of 3 to 6, they come, they learn the basics and get and not only education, out of the there are many tools used by SWADHAR, which was during their visit, everybody have known these tools they have seen in the centers. Then we have study class for bigger children who come and study, and they just come there, sit, study, and the teachers help them if they have any doubts. It's providing an environment where they can comfortably sit and study. Support class, here the children are really supported mostly in maths subject and in their local language of Marathi, which are the 2 weak subjects. They normally told English also they are able to coach up with, but Marathi they feel it's very difficult. Same also in Tamil Nadu, I see Tamil is something difficult to learn, they will say. Yeah. And we have library and e-learning. E-learning is a computer education which we are giving to these people who are first time learners of computers as such. Then we have awareness programs and staff training, which is, and then we have early childhood development. We are working with the pregnant women with the 18 sessions of curriculum, which for the holistic development of the children. We have family counseling centers and the family guidance program, which is, mostly related to, if Aditi was here, she could have shared something related to the gender-based violence and, all happening. And all those case studies are very, very alarming to see, and how they have been working to ensure this is a thing. They do also the occasional training center programs, like they have beautician and tailoring courses going on, and they also provide them employment opportunities through this. This through ProAction, we are working with Women and Child Care Project. This project started with just training, first with training of women in 2016, where we trained few groups of women on tailoring. So later, this group increased, and they started, got trainings, and then we were helping them on getting orders. So earlier it was just school uniforms for schools, and and followed by some soft toy making. But then with this, with another business unit called I Was a Sari. We brought a change in this activity where that business unit wanted to it is an Italian organization headed by an Italian who brought trainings from the Italian university there, where saris are changed into a lot of accessories. So, and they got international orders as well as local orders. By 2018, from 2016 to 2018, they became sustainable. They are getting around about really 80 lakhs of value of turnover they are doing, and they are 55. They are now not just the trainers or a tailoring person. Now they are called as artisans. So they are sustainable. So we are now not supporting these women's group, which they get orders, they are ensuring and they are getting the earnings. But now we are supporting them only for the social activities, like providing a daycare center for their children. It's like a drop-in center where the 55 artisans children are dropped. It's from not for only the small children till they do their +2, they come here and they study. There is a morning session and the afternoon according to the school timings. Apart from just education, we are giving them English coaching classes, art and craft classes, karate classes, chess classes, like many activities are going on for these children. Then we are providing even scholarships, like educational support for these 55 artisan children. Health checkup is given both to the women's group as well as to the children of them. Family insurance are provided. And this year we brought in e-learning for these children through, they are learning through computers. So this is also called the House of Smile. And this is how all our projects have been. And everywhere gender is our focus.
Okay, thank you very much, Ali, for that fascinating talk about the work of CESVI. I allowed it to run on a little bit because we're one speaker down on this session, so that gives us a little bit more time to hear from our speakers and perhaps to discuss things. Would anybody like to ask a question or raise any points for discussion? Oh, Nadia.
Only if I'm allowed. I feel like I don't want to hog the time, but first of all, thank you, Ali, so much for such a detailed presentation of the amazing work that you do in India and internationally. I think this is an amazing portfolio of work. I think I probably will speak to for everybody. I have two questions, if I may. One is about the work that you do, particularly internationally, and it's interesting to see the structures that and processes that you govern within the NGOs. And I think this kind of structural support that you provide, I think, is so essential to be able to look at that. And also looking at the kind of programs that you do, looking at children, looking at GBV, looking at kind of the soft skills and educational skills that, again, help a lot to mediate impacts of GBV, empower women and communities to address that topic. I'm leading to a question now. So if you look at the international work, is there any kind of key features of implementation or impact that you think are absolutely essential if we are to champion a topic such as GBV, let's say, in different international contexts? From the profile of CESVI, from experience of CESVI, would you be able to say what things to keep in mind to be able to implement things internationally? That's my first question, and I'll let you answer that if it's possible. I know it's a difficult one.
No, it's not difficult. Actually, what CESVI follows in any project, we find the need assessment first. Like, every time sitting here, we have all kinds of internationally, we know we can do it in a different way, in an innovative way, innovations, all that comes in. But we really plan an activity in a bottom upward only. So when we are writing the proposal or we are thinking, we just go to the field, we do the field assessment, we talk with the community. If we are working on gender-based, for example, we will design the project only after interacting with the community, knowing their needs. And there were sometimes, I still remember when we were going for a children project in Kadalur in Tamil Nadu, we completely had another law framework in our mind, and we also almost structured our proposal according to it. But when we did our need assessment, it was completely turned out. All our programs changed. The criteria changed a lot. So I feel this is the best way to see the impact at the end. Otherwise, in between, we need not change. We do that also in between. Again, we do an assessment, but this can be avoided, I feel. So I look at that as something which CESVI has brought that here. That's one I see.
I think excellent. I think that's so important, because I think we sort of sometimes look at universality of it all, isn't it? Oh, we found an answer. This is the way to do it. That's implemented everywhere. And what you say is just so key to say, actually, when you're going into a context, be ready to change things. And I think what we're learning as well with the GenViR project, by talking to communities about ways, even different communities, the Hijra or women, same topic within the same locality, you need to adjust, you need to kind of understand constructs differently. My next question, and I'm sorry for hogging the time, I'll be very quick. You teased at the beginning that you've had many conversations that did not make your presentation. Could you maybe say a few words about maybe the learnings that you've had by talking about GBV to policymakers and colleagues that you maybe didn't make your presentation?
But I can share you some of the writings which I've done. I literally, after that 10 days, I forgot about it. But the policy and bridging the gaps between the NGOs who are working towards the policies which are already there. There are policies, but they are so silent. So how the NGOs are working towards that? Okay. So it was something very surprising to me, like these, what we call now, what we wanted to make the change, whereas policy already in India. But the awareness was not given there, or it was not taken even, now after the certain instance, they just pop up with all these are there. So I can share you the documents which I made it. So it might be useful to you. So I prepared a small, a few 4 to 5 pages, so which will be helpful for
That'd
you.
Be wonderful. That'd be so useful. Absolutely. Thank you.
Okay, well, I see it's UK time, reached the witching hour of 1:45. So perhaps on that note, we could move on to our next speaker, who's, I see Aditi still not joined us. So let's move on to, well, a man I met a few months ago via our mutual friend and colleague, Monica Lackenpaul, who came across to me as a very modest, unassuming man. But don't let that fool you. He's got a career which spans at least 2 continents, to my knowledge, India and North America, who's both a medical doctor and a public health researcher and practitioner. Raj Panda, who's kindly agreed to contribute to the workshop today. He's currently a professor at the Public Health Foundation of India and is involved in designing and evaluating behavioural interventions for healthcare providers, in using implementation science theories and frameworks. He's also quite a prolific writer who's contributed a great many journal articles, book chapters, and so on, and edited books, as well as more popular media such as blogs and social media, and has also found time in his schedule to be an advisor to non-profit organisations such as ECHO India and, again, another organisation whose acronym I can't pronounce, Friday. Sounds a bit like Friday, I think. And also has contributed to the World Heart Foundation in Geneva. His current research interests are on how health systems can address GBV by different modes of integration. So take it away, Raj.
Thank you, Bram, and thank you, Nadia, for this opportunity. As a disclaimer, right, I'm not a gender expert by any yardstick. My area of work is health system research, and within the health system research, it's but obvious that gender plays an important role, whether it is in the writing of proposals for gender and equity lens that we have to integrate, or in the collection of data, or in the analysis. That's a mandated thing. But beyond the obligatory thing that we all have to do is also a realization that many of the programs that we evaluate do not really seek out to see gender-based violence against women, or other things that should have been evident. And across 2 decades, my experience with health systems have made me realize that this is often the invisible silence that many researchers choose to ignore, or to, at best, to give it just a formal, the tick box to put it into our proposals. So my talk today is more based about my own experiences with how policies and programs deal with gender-based violence. Since the time offered is only 10 to 15 minutes, I'll be very short. But yeah, we can have a conversation after that. Allow me to share my screen. Not a great fan of PowerPoints, but just to make, since we have limited time, I would just go ahead and quickly share with you a few points from my presentation. Is this visible to all?
Yes.
Yes.
Thank you. I think when Nadia asked me to talk about vulnerable communities, been with specific vulnerable communities, as for instance, migrants, or with vulnerable populations, like indigenous people or tribal populations. But I work in Odisha, and Odisha has the second largest tribal population in India, which is a huge, which is huge by itself. And there is an intermix of a lot of populations, there would be a lot of people who belong to these vulnerable communities. And especially since I work in cardiovascular prevention, apart from working in maternal child health, I also work in cardiovascular prevention. I work very closely also recently with the World Heart Federation in advising them on how to scale up, treating risk factors like tobacco and alcohol in tribal populations. Tribal populations do have an increased risk of such risk factors for non-communicable disease. So yes, within vulnerable communities, we are not worked specifically in vulnerable communities, but this happened to be in the area in which I work in. This is the area in which I work in many of the projects that I do in Odisha, and then in as simply not just populations, but many different ways of looking to them. For instance, people presenting in primary care, and my area of work is most of my projects, my trials, my implementation science, and whether it is in maternal child health or in addressing risk factors for cardiovascular health, it takes place in primary care, which is the first port of call for the most vulnerable populations, because the rest of the population actually go to private sector. And it is here that you see a lot of this vulnerability coming from women, girls, other risk groups like adolescent girls with teenage pregnancy, young women, women with disabilities, pregnant women, women with mental health disorders, migrant populations, as well as tribal and other marginalized communities. And for many people, within the communities, there is a lot of violence. There's a lot of violence related to the condition, whether they're pregnant or they're teenagers, or whether they belong to a particular community or a clan, if you can say that. The only point of contact sometimes is actually the healthcare provider. It could be a primary care doctor, it could be a nurse, it could be an ASHA worker, a community health worker as is known in India, or it could be A&M or a nurse midwife whom they go to for the ANC care and so on and on. So I believe with a little with my limitations of understanding GBV, that GBV is not only a human right, but first and foremost a public health problem and needs to be seen as one. And why do I say that? Because very often healthcare providers are at a higher pecking order than the people who come to them, and they are in a position to offer not just immediate medical attention, as maybe in the case of violence against women, as in rape and other conditions, but they also can link survivors to other needed assistance, including particularly mental health and psychosocial support, because that is in some ways available within the health system, not the best, but in some ways at least available within the health system. Social services, because it's again linked to ICDS or the Women and Child Development, which has close connections with health. And increasingly, at least in our country, there is a protection officer, there is some legal aid, and so on and on. So briefly, this is what has been really my experience with health systems and GBV. And GBV is a very loaded term because India people recognize GBV in different terms and different manner. And within the health system, people do not recognize GBV, excepting emergency post-abortion care or abortion or treating a rape victim or the best inter-partner violence, IPV as it is called. And there is some orientation around that for healthcare providers. But GBV can be more than that, and as we all understand. So again, as I said, I just have a few slides. So just some thoughts on this. What is needed is within the health system also is to understanding, and within the health system and outside, because this is multi-sectoral, right? And I think the previous speaker alluded to a lot of those discussions around multi-sectoral, is to understand the impact of this gender-based violence on the health and well-being of women and children. So understanding the impact of GBV and health and well-being of women and children makes it more makes it as an indicator that needs to be counted rather than as an abstract, more as an academic abstract or an abstract people live with day in and day out. So and seeing numbers can actually can motivate policymakers and program managers. And I'll speak about that a little more in my next slides. The next thing is so one is understanding the impact of GBV. The other is improving health workers and managers understanding what is required for a survivor-centered effective response and not just a routine addressing that particular thing. Traditionally, doctors, nurses, and other administrators in health systems are geared towards responding very quickly to the particular problem in hand, and that's great because you cannot talk about human rights when somebody is bleeding on the table, right? You need to cauterize, you need to treat that right away, and so on and on. And that's how efficiently the health system functions, the healthcare providers function. But beyond that is a larger visionary or a more broad brush thing that is not there, and even I would say not there with the WHO guidelines. That and understanding how a survivor-centered effective response can be done, which is always limitation within the system. And the final thing I repeat again is that what's very important is to look at metrics of measurement. I know Nadia and Brown and all of us frown upon universality of some indicators, but without those indicators and targets, we will not even be moving. We wouldn't even moving inches. Forget about miles. So I think metrics of measurement and some indicators are very important, and they tie in very well with the SDG goals, particularly 3 and other important SDG goals related to health and welfare. So what is the solution? Again, is based on my little reading and understanding my own work in systems approach towards solutions, whether it has be maternal child health, whether it is related to addressing risk factors for NCDs, cardiovascular prevention programs, or policy document. I think a systems approach is the best way to go about it, and because it is not just one piecemeal, it's not just one piecemeal solution. It is a whole meal by itself. And so, what are some other things that you look in a systems approach? One, of course, is support and empower providers. Remember, providers themselves need to be empowered to be able to understand and to be able to act, right? One of the most easiest thing and one of the most difficult thing at the same time is ensuring infrastructure for privacy and confidentiality. And I say this because when even a simple thing is being able to interview somebody who, for instance, a mother who's experienced perinatal depression. Even if you were to interview a mother in the primary healthcare center or a secondary care or a tertiary medical college, maybe in a medical college it's more possible. But privacy and privacy is a very huge issue, and so is confidentiality, which is why the tip of the cases that are reported are usually a tip of the iceberg, while a huge mass of problem really floats underneath. The second thing, of course, the third thing, of course, is ensuring that standard and protocols and SOPs are there in place. Doctors, nurses, and medical practitioners, by and far, respond very well to SOPs. Referral networks, again, very important to put into the system. Many people would not know what to do if a patient, if for instance, a perinatal mother talks about abuse at home because she is depressed. A doctor would just, an OBGYN would ignore it or suggest some other way to for the mother to make it up to a family or some other place, because she doesn't really know that the mother's depression is an effect of the GBV and not the other way around. So referral networks are very important, and within the health system, there is increasingly a lot of psychological and psychiatric care, more psychiatric care than psychological care, but nonetheless, some sort of a referral network. And network not just to psychologists and psychiatrists, which is probably the easiest thing to do, not always, but certainly the easiest thing to do within the health system, but even refer to a social worker and a protection officer and other things that are slowly being in place within that place. For instance, if it's a primary healthcare, secondary healthcare, there are block development offices where somebody can go to. If it's a district level, there is social protection scale and women's science development officer that people basically go there. But very often the doctor or the nurse or the midwife who's tending to the mother do not have an orientation about what to do about it. So clear-cut SOPs which has referral networks in place, and enough place for documentation, etc., etc. And just as an example, UNICEF in all its program started using the AAAQ, which is the availability, accessibility, acceptability, and the quality framework. There are different frameworks. WHO uses the health system framework, UNICEF uses the AAQ framework, and basically to understand whether victims can actually access social services through some simple questions. Within the system, integration is critical. Without integration, it's very difficult to do anything. And it's suggested often that there would be a parallel service, but that would be not cost effective, but also hamper existing services. The argument against integration, which has some weight, is to say that in primary care, healthcare workers are overloaded. They are doing 200% more than what they should be doing. In some cases, 300% more than what they should be doing often, and that results in a lot of abuse, flare-ups, arguments. When and when you don't have time, you obviously don't have time to talk to women about their problems beyond what the medical problem seems to be. So some people say parallel service or a referral service, but I think like our experience with NCDs, addressing NCDs, where doctors do not really counsel for risk factors. The new paradigm change to say, realize for long that doctors do not have time to counsel for NCD risk factors or chronic disease. And there is a necessity of something else in addition to a doctor who should be there. And that's slowly starting to take place in India. And in many ways, in the health and wellness centers, which are primary care services currently, which has received a lot of policy thrust within the government. But definitely, and if it's happening in primary care, it will happen everywhere else. But at least that's because everywhere else that there are more resources and more and better planning. Integration to incorporate routine screening also. Again, we talk about privacy and confidentiality because that's very important. But beyond that, of course, to healthcare, beyond this training and sensitization is support, of course, because a one-time training alone will not solve a lot of problem. Very often many of us, including me, are guilty of saying, okay, this is a problem, I need assessment, and they need a training. And that's good. That's a starting point. But beyond that is an effort, as I use the term, empowering providers is a long journey. And the only way you can integrate that is not just to move away only from a simple piecemeal training. Finally, a lot of things have changed in healthcare because there are protocols and there is some accountability. And I think that's incredibly important if we are to make change in the system. Before we go to operational issues, a quick reading of literature led me to understand that there are a lot of pilots happening in India. One, of course, is the CESVI, a well-known NGO in Maharashtra. There was a pilot with WHO as a partner organization in Sangli district in Maharashtra, where they were able to look at, they call it violence against women. They didn't call it gender-based violence, but they piloted it in a couple of hospitals, including different levels of the health facility, and mostly tertiary and secondary care, and saw that it was possible to do that. And there are other pilots I know in the south of India, which are looking at a possibility of integration of this sort of gender-based violence into healthcare provider. It's a starting point, but nonetheless important one to take note of. Then of course there are a lot of issues around this. So some we know already are usual suspects. Funding is always an issue within the health centers. Where would you want to intervene first, or should it be parallel? Lower centers, scarcity of resources are less likely to implement. Support is quite difficult to obtain and time consuming, in the sense that support from allied health workers, support from intersectoral and multisectoral other organizations, legal issues. The system itself is fractured. There is a public and a private dichotomy, and private sector often will do a lot of superfluous things and camouflage it because they don't want the practice to be affected. And remember, in India, close to 70% of OPD and close to 67% of IPD or more actually takes place in the private sector. Even though we have a huge behemoth public health infrastructure, people still go to private sector because of issues of quality and because they think that they're getting better services there. Finally, again, as I said, the health system does address to some extent sexual violence because it's integrated into the reproductive child health, reproductive maternal neonatal child health services that have been there as a public program, a national program in India since the last 25, 30 years with different acronyms from time to time. But they do not uniformly include clinical health policy responses for emotional or economic violence. So they're just not there in the system to understand emotional violence, economic violence. And I think what they do best is to address the physical part of it, which at least is starting point again. And I speak not only of India, but in most countries, including wealthier countries, including the UK and other countries in the West, where providing privacy to survivors within health facility is usually a universal challenge. And I'd like to know what your thoughts are on those issues. A lot of technical issues. Knowledge itself is an issue. Skill sets are issue. Training, and very often not the training is left to the lower levels of trainers, or sometimes just contracted out to NGOs, who, I mean, in some cases do very good quality of training, but in many cases do not seem to understand the whole thing of integration, because their job is to do what they're paid to do. And in policy, I think my previous speaker did speak about it, and there is a huge institutional silence on GBV. By and far, very few policies do a comprehensive integration into GBV. And I found that when we were doing, found that very challenging when we were doing universal healthcare document for policy for Government of India in 2012. Commissioned by the Planning Commission at that time, what is currently known as Niti Aayog. So institution silence is definitely an issue, and of course, both resources as well as capability for monitoring and evaluation remains a huge problem. WHO has this global plan of action. I don't want to go into detail with this. I've already spoken about this, and I think Brian, how am I doing for time? Do I have 5 minutes more? Sorry, Brian.
Yeah, I'll mute myself there. Yes, it's 1:10. We've got until 1:30, so maybe a little more, and then we can break for questions and comments.
Okay, I promise I'll be done by 5 minutes. The Global Plan of Action, simply called the Global Plan, in 2016 was adopted by 174 countries. WHO guidelines, so that health services should be able to address IPV and comprehensive post-rape care in line in the National Health Plan policy. So you can see nothing really on GBV, but only a part of it. And at the best, violence against women, VAW as it's called. So this, like I said, a starting point, but a long way to go. Apparently, there should be a population-based national representative study or survey. I've looked at the recent NFHS 5. The NFHS 5 is a DHS, the Demographic Health Survey, which gets done in every country around the world. We call it the National Family Health Survey. And the last one was done, in 2019 and 20. And while the difference between that and the previous one, which got done 5 years back in 2016, it seems that there is a decrease in gender-based not in gender-based violence, in violence and let me say that right, sexual violence and sexual violence and otherwise in communities. The findings are very I mean, there's a 4% reduction really, but the findings are by and far applied to India. It's very different for different states and definitely different for different districts. In fact, NFHS does give you statements, give you specifications about districts, because the data is from districts with a large sample. So it'll be very interesting to look at it. I haven't had time to look at it because, again, not an area that I work in. It'd be very interesting to look at secondary data to look at that. The other important data that one could look at is NSS, which is again a very large sample size. So these are some thoughts that I leave with you. Plan for action. Within the health sector policy frameworks are less developed. A recommendation is that ministries of health and departments of health should put them across different health programs and health sector policies, not just related to FRH and HIV. Currently, the focus is on that, and there's a lot of work in that. but taking a cue from it, learning from it, we could look at other sectors, other programs that are currently running. I know, for instance, that NCTs do not address GBV in its entirety, and it should, because it's chronic disease in some ways. Like I said, addressing the prevention of gender-based violence against women in policy is relatively new, as historically much more attention has always been paid to response or emergency services. Thank you so much. I'm happy to take questions and some references. I will continue to share the slide if you have any questions, or I can, if you want, I can.
Okay, well, thanks very much indeed, Raj, for another fascinating presentation. Has anybody got any questions or comments for discussion at all?
I do, as always.
Nadia's unmuted, so you'll. Would you like to kick off the discussion, Nadia?
Yes. Thank you, Raj, and that's such a fascinating and again quite detailed presentation, and very, very useful. I think this will serve as a guide for many projects. Thinking about all of the issues that need to be tackled in order to kind of introduce equitably conversations and implementations around GBV in health systems. You've mentioned policy silence, and this is something I wanted to go back to and maybe kind of open it to both speakers today. We've had our conversations about kind of implementing policy change, and I think this is sort of seen as a holy grail within UK research. Is like, well, you want to do impact, you need to kind of demonstrate policy change, and you've achieved kind of this status. I understand that this is a bit more of a sensitive field in India, and I wanted to kind of maybe solicit your thoughts around doing or arguing to do policy change around GBV in India from both yourself and Alli, and maybe some of the things that we as researchers coming from the UK need to be sensitive to in order not to be kind of a bull in a china shop trying to implement our holy grail in the Indian context, and how do we do that in a GBV sense or health system sense?
Can I go, Nadia, first? Yeah. Okay, thank you. So I think, well, it is a very important question about policy change. And I think, as I said, for policy change, as all of us know, the system has to be ripe for it in the first place, right? First, is the system ready to even absorb the amount of what you could do? You could do, the most wonderful work in the world, state-of-the-art research. You could have, RCTs, which very significant OR issues and so on and on. But in the end of the day, if the system is not ready for it, then there will not be any policy change. I think because of the effect of globalization in one way, and because we live in a global village today, and there is a lot of pressure on it, creating local evidence for policy change will or may work. I say that with some caution, but may work, number one. And policy change, and I know this, and I know this, how funders want to do it. Within 5 years, you have a project and you want to bring about policy change. Policy change is not dating; it's a marriage, right? So, and in a marriage, it's difficult, right? It's very easy to say, okay, in 5 years you're able to do implementation science, maybe not even sure. Maybe you can do an RCT, and maybe you can bring about one RCT, and then there are policy makers just as lip service to the entire thing. Says, okay, we will do this, we will do the integrate. So I think policy change has to come from communities also. And I think that's what we talk about. And there has to be a demand for policy change. So how do you do the demand? You are talking only about a supply, right? From a pure economic point of view, you have to have a demand within the communities that you work in. Do communities really want GBV integrated into systems? In this case, let's say the community is a health system community. I'm not even talking about communities, the larger community. Within the health system, have we ever gone and talked to people to understand how does GBV actually affect the practice? Will it make them more human? Will it actually help them in the practice? Will it actually, and there are a lot of issues and challenges, but there'll also be champions within the system who will be able to do this. Can you, for instance, I cannot name immediately any health system champion, and I know a few. I can name a champion for tobacco, I can name a champion for NCD, I can name a champion for maternal child health, I can name so many champions. But can I name a champion, a single champion for GBV? And I do not know. I know I have done limited work on this, but I do know the public health world. It's not a very large world by itself. So that's it. So do you have champions within the health system? Does the system need it? Is the system prepared to absorb it? If so, what is the cost? The cost is not just money. The cost is in many ways beyond the money. It's integrating it into the medical curriculum, because they are doing it right now after many years of negotiation. It's and just the medical curriculum, not the nursing curriculum, and that's strange, right? So integrating into all allied healthcare workers, that itself will take years, if not decades, right? And a quick short policy change is very often, I say, a dangerous instrument. It is a dangerous instrument. It's all of us. It's like a license to kill. One should not go down that path.
Thank you. That is such a deep and thoughtful answer. I think that's definitely very, very useful for us to kind of reframe our thinking about kind of addressing that in where you start. Thank you very much for that.
Yes, that's very much my impression too. The law or policy is often a very blunt instrument, and yet it is one that politicians tend to reach for. Oh, no, there's a problem here. I know, let's pass a law about it. That'll sort things out. Often without doing any cost-benefit analysis of what that might lead to and whether it will indeed help the most vulnerable. Yeah. Any other questions or observations that anybody has?
Now, as when Nadia was sharing about these policies related to, yes, there are many government policies. They play, like, actually government is showing some signals as commitment for tackling all these GVPs, and provide like many foundations of coordination actions also. Like they have established helplines, shelters, then support services as such, and also like vulnerable people, and also medical care. So there are policies in the framework for set up by, but somewhere, as you know, I remember reading, like, NGOs are closely engaged with the community. So there should be a collaboration work between the NGOs and the policy makers. This can be bridged if there is more they are doing, but due to certain issues or some struggles or political power, they are not able to work towards. But even in medical support, there are government policies for gender-based violence to get them justice and medical care in the policy as such.
Can I quickly add to that? I think that's a really good point. And I think depending which systems as well, and Raj, you're speaking from the health system perspective. So just from having very brief conversations, for example, with the Hijra community when we visited SWADHAR in March. And it was interesting to have a conversation with them in terms of their vulnerabilities and strengths and what their needs might be around kind of the context that they're experiencing, because they're highly stigmatized and experience quite high levels of GBV in society. And when we asked specifically about healthcare and say, is there any barriers for you to accessing healthcare? No. And in their words, it's sensitized. Healthcare sensitized, we can access, that's not an issue. Education is a different issue. So education system is where maybe some of the issues around values, beliefs, and notions around a particular community is coming through, and they felt excluded at a very young age from that. So it's quite interesting to see how different systems kind of manage certain groups and communities. So when we speak about change, I guess, in terms of healthcare, whether there is something in terms of, everybody deserves treatment, everybody deserves health, that type of thing that came first, where in their kind of words, they said, well, that is sensitized, education isn't. So it's quite an interesting insight for us.
Yeah, in terms of accessibility, Nadia, I would agree. I think there is a movement in the last 20 years or so, last 2-3 decades, about universality of healthcare. So, I mean, in terms of accessibility, yes. My point was really about within the institution, how are you addressing them? How are you addressing beyond IPV and, treating post-rape, like I say, and just that itself is a wonderful thing to start with, that it's happening. It was difficult when I was a primary care doctor some 25 years back. Honestly, I had no orientation about what did I do if somebody did come out. It's more like a headache for many of us, because because the framework, you're left alone there. There was nothing to fall back upon. There's no system. Thankfully, that has changed now. So in terms of accessibility to people are different, not just binary, but otherwise accessibility, treatment to some extent, I don't think there is a lot of discrimination, but then that can vary across India, across states, across facilities and so on. I won't say there is not discrimination at all. There is, but maybe not as much as it maybe is in other sectors, as you say. But the whole thing is, what do I say? The wholehearted response to it is not, because I believe that there is, and I started my first slide saying that it's a public health problem. It's not seen as a public health problem by the health systems, and that is where I think our efforts are needed. A mother who comes in a perinatal month, and this area very close because we've been talking about the last 1 year. A perinatal depressed mother comes into the system. She may get the best medical care. Best is a relative term, but in terms of beyond medical care and some psychiatric drugs which may be prescribed, what else? And that's not the entirety of actually of solving the GBV or on that. So, and I give you one example. There are hundreds of such examples.
Absolutely.
Okay, any other questions or observations from anyone? Okay, well, in which case, if everybody's gone quiet, maybe I could ask a question. I mean, we talked about, you mentioned, Raj, some of the pressures already on frontline healthcare workers. They're already very busy and exhorting them to deal with gender-based violence might be another layer of duty, which they may, puts them under even more pressure. And, Ali was talking about NGOs and non-profit sector organizations. Is there any way in which we can help build capacity on the part of healthcare workers or members of NGOs to deal with this more effectively?
Brian, the time of speaking, as I think the previous speaker also alluded to, Ali alluded to, I think some trainings are going on, but that's it. So trainings are going on, which is a starting point. I think if you look into, I very recently did a evaluation of a large cohort of ASHA workers who were trained by our National Health NHSRC, which is the National Health System Resource Center. And there is an entire module based on gender-based violence. And ASHA workers live in villages, right? ASHA workers are community health volunteers, community health workers who actually live in villages. And their task is actually mostly maternal child health, but now they're being used for other non-communicable disease programs and malaria and HIV and so on, right? So there is an initiative where ASHA workers are being trained by the module. So that's the starting point. But beyond the training, I mentioned several other things that we should look at. Is there a system response to it? Are there monitoring indicators for it? The WHO thing about so training, the there is a health system framework which talks about resources, training, financial services, monitoring and evaluation, and I'm forgetting what the fifth one is. But yeah, I mean, things like that. So the entirety is missing right now. So a holistic program would have everything in place, right? I mean, so you have the training, so what?
Yeah. Ali, perhaps I could come to you. How could one increase capacity in the sorts of organizations you're familiar with?
Actually, to talk about, we have not worked so much on health as such a sector as we could have seen, but in the education part, we work with the Anganwadi workers. We provide training for them. Okay, so they also, Anganwadis are maintained by the government. Yes, they come, they just feed the children the food in the afternoon, which is a mid-meal meals food given by the government, and they ensure that their work is over and that's it. But we started providing training to Anganwadi workers on the how to handle the children, both psychologically as well as their what kind of how to teach them and all that, which is in the if you would go and see, when the Anganwadi comes in, they go for a small training from the government sectors where all these are shared, some materials are shared with them, but that's it. They are not given continuous training on that, or they are not monitored as such. But since we are working on education in and around, like when I said my House of Smile, where we are working with around about only 10 villages there in and around our shelter care. We ensure like all the Anganwadis training program is given to their teachers there. They come, even the helper who is in Anganwadi comes, we train them how to handle children, what to be taught, like their skill, like what kind of education to teach them, and how to take care of them, all that. But we are working with the PHC, but not providing training as such. As I said, we did not go to that extent on health checkup. We take PHC support to come and explain to our group of community people or about any diseases or any awareness on those awareness days like that. But to be frank, on health sectors, we did not take up.
Okay, thank you. Well, I see it's reached 1:30 here in the UK. Once again, I'd like to thank very much our speakers. We were intending to have 3, but the 2 we did have certainly rose to the occasion and provided us with many fascinating things to think about, and perhaps ideas to incorporate into future projects in due course. So thank you very much, and thanks, well, especially to Nadia, who was asking questions and turning the pages and presentations and so on. So good. We've got another one in this series coming up, but not next week. It's coming up in October. And I think we'll be circulating a Zoom link in due course. But I thought I got the exact date, but it just says the 6th one in October on the
Yes.
paper I've got. Hold on, I think I might be able to enlighten you. It might be the 12th of October.
Yes.
On another schedule that we prepared. So yeah, I hope you'll be able to log in and join us then for a final sandpit event to showcase some of what we've learned in the GenViR project so far.